It's a pleasure to invite Professor Mats Borjesson from Gothenburg, Sweden, medical director for the Swedish women's football team, and he was integral to the coronary artery disease section of the sports cardiology guidelines. He will speak on the veteran athletes' coronary arteries, what to expect. Over to you, Mats.
Thank you. Thank you, Sabia, and thank you, Antonio. I hope you can see the slides well now. And my task is to talk about the veteran athletes' coronary arteries, what to expect. And I must say it's a privilege to be part of this CRY program. I think it's for the 11th or 10th year in succession, and I'm just very sorry that it couldn't be in person in London. Veteran athletes are more common, and I think a definition is a good way to start. We define master athletes as somebody over 35 years of age, and sometimes 40 is used as a border. But when it comes to the veteran athletes, they are usually defined as someone over 50 years of age who take part in organized form of competitive sports, and these are mainly endurance events. And as you know, these events are, at least pre-COVID, increasing heavily in the world. The dilemma with the activity of high intensity, high up in ages, is that, of course, regular physical activity has multiple health benefits. But high intensity activity, such as sports, may be associated with an increased risk, especially in individuals with underlying cerebrovascular disease. And these are mostly subclinical. Looking here at the Swedish National Comprehensive Registry of all sudden deaths under age of 35, we can see that coronary artery disease, actually in orange here, actually causes some of the cases of sudden cardiac death, be it exertional or non-exertional, already before the age of 35. But after the age of 35, coronary artery disease is the main cause by far of sudden cardiac death in association to sports. And of course, this is because atherosclerosis is a progressive disease starting early in life, so it will cause also some deaths early. But the main drivers of this process is age and sex. And of course, also the traditional risk factors for atherosclerosis are part of this risk factor palette. So what do you, as audience, expect of the veteran athletes' coronaries in the future? Will we have about the same level of coronary artery disease, less coronary artery disease, or more coronary artery disease? Please cast your votes.
Thanks, Matt. So, what can we expect of the veteran athletes' coronaries in the future? More coronary disease, about the same, or less coronary artery disease? Just waiting for the votes to come in. So far, I see about 100% voting for more coronary disease, Mats. So we've got 100% for more coronary artery disease, but the people are still voting. So let's see if anyone has anything else to say. 0%. Oh no, we are getting some votes for about the same or less coronary disease. So it'll be interesting to see where we come with that. But the majority is for more coronary disease, as one would expect. So we've got 57% for more coronary disease and around 30% for less coronary artery disease and about 20% for about the same. And I believe people are still voting. It's interesting to see where the majority have voted. So 52% for more coronary artery disease. And people are still voting. It's good. This is fantastic that they're all participating. So 50% for more coronary artery disease. And we've got 27% for less coronary disease and 23% for about the same.
Okay, thank you. So this is the final votes then. And of course, we cannot say because this is the future, right? So, but I would give my case because I believe there's strong evidence for that the veteran athletes, coronaries, will have more coronary artery disease in the future. And the reason for this is several. One of the reasons is that plaques are very common in middle-aged unselected people. And this is results from the Swedish SCAPI study from 50 to 65-year-olds unselected Swedish population, mostly people from Gothenburg, by the way. And these are selected in these are divided into men and women here. Men in black and women in white. And as you can see here, above the age of 60, between 60 and 65, 77% of men in unselected population do have coronary plaques on angio, and 47% of women. That means that somebody unselected from the population at the age of 60 will have the chance of having coronary plaques are greater than not having it. Also about in runners, you can see here that this is from the Two Ocean Race in South Africa. And we can see here they are about 42 years of age at the mean age. And you can see here that existing cardiovascular disease is about 2.3% in a self-assessment. And that means that 1 in 43 runners have a history of existing cardiovascular disease, and 1 in about 200 runners have a history of existing coronary artery disease. But these are younger and well below what we call the veterans. What about the slightly older athletes? This is results from the Swedish Lidingö cross-country race, 30 kilometers, very tough race. And as you can see here, highlighted in red, there were 185 participants, mean age of 61, that were tested by NT-proBNP. Of these, 15 had increased values, and 4 of these had serious cardiovascular disease, about 2.2% of the whole sample, and that included 2 persons with advanced coronary artery disease and 3 vessel disease. That means that at least some asymptomatic veterans do have severe coronary artery disease, and this is actually a problem in the older runners. We can also expect plaques, but we can also expect more calcified plaques. This is a study from Vincent Angevier and colleagues. And as you can see here, the runners with a lifelong exercise volume over 2,000 MET minutes per week had significantly higher CAC score, but also significantly more calcified plaques compared to those with a less exercise volume. So that means we can expect plaques and we can expect more calcified plaques. And that might be how that relates to risk. It's not totally clarified, but this study is also supported by evidence from the London group of Mogani et al. And we also know the last reason why we get more coronary artery disease is that the runners are getting older and less fit. Also from the Lidingö race, we can see the development from 1993 to 2007. The runners were getting older, the mean age of the runners were getting older, but also the mean running times increased in all finishing quartiles. So what you can say from this is that runners are older and less fit, and that means by a very probable reason that they will have more coronary artery disease. So my next question is, what is important, do you believe, about the stress test in evaluation of coronary artery disease? Is it that you can use any functional stress test in the evaluation, or the stress test must be an exercise test on cycle or treadmill, or the stress test must be symptom limited? Please cast your votes.
Thanks, Matt. So what is important about stress testing in the evaluation for coronary artery disease? I think it all depends on what your main imaging speciality is, I think, Mats, but let's see what the audience feel.
Yep.
Any functional tests can be used. The stress test must be exercise tests, either cycle or a treadmill, or the stress test must be symptom limited.
Of course, the questions are, you can always say if and but and so on.
think also it also depends on the availability.
Yep.
What's available at your institution. So it'll be interesting to see what our audience actually feel. So there's people still voting, and you'll be very interested to know it's neck and neck between stress testing with exercise treadmill or cycle versus symptom limited. Some people have also voted for any functional test. So, okay, so I think the majority are voting for the stress test must be exercise test, cycle or treadmill. But there are still some votes coming in. Okay, so I believe people are still voting. Okay, so we have got a third voting for cycle or treadmill, about 30% for symptom limited, and about 30% for functional tests. Any functional test can be used.
Okay, thank you very much. So probably that says a lot about the quality of the question then. I should have been clearer. But anyway, I think the point here is that the stress test is usually an exercise test on cycle or treadmill, but it mustn't have to be that. It could be another test that are equivalent, another stress test, a stress echo, and so on, for the same reason, because of availability and the knowledge about the tester from the tester and so on. But also, it mustn't be symptom limited. It has to be truly maximal. So this has to be question A or answer A here. But I will try to give the reasons for that. So when it comes to the 2020 EC guidelines on sports cardiology and exercise in patients with cardiovascular disease, it's interesting to see those who have risk of being over 35 years old, and that is the veteran athletes. You should first evaluate the CVD risk. And if the CVD risk is equivalent or higher than 5% according to the European score model using the traditional risk factors, then you should consider the intensity of the physical activity. And if that's high or very high, then you should do a maximal exercise test or other functional imaging having the equivalent procedures or CTCA. That means that you mustn't only maximum exercise test is possible. And if that's normal, you can do, you don't need any further investigations or no restrictions. So question number 3, what is the key in the evaluation of veteran athletes regarding coronary disease? Is it anatomical evaluation? Is it anatomical and functional evaluation? Or is it the diagnosis of coronary disease or not in those athletes? Please vote.
I think this is a great question, Mats. What is the key in the evaluation of the veteran athletes regarding coronary disease? So do we just go for the anatomical evaluation, anatomical and functional ischemia assessment, or the diagnosis of coronary artery disease? So please cast your votes, and it will be interesting to see what our audience think of this poll. I do have to say, Mats, the diagnosis of coronary artery disease, would you say in individuals with symptoms?
Do you mean as a question or?
Well, as a question, yes.
Yeah.
Would you, in symptomatic coronary artery disease, would you say?
Yes, these are, you know, we don't know if these athletes have coronary disease or not. That's in the question.
Okay. So people are voting. The majority have gone for anatomical and functional evaluation. 14% so far have voted for anatomical evaluation alone for high-risk features.
So they could have symptoms or not, Sabia. Yeah.
And 6% for the diagnosis of coronary artery disease. So far, the majority have gone for anatomical and functional evaluation. Okay, the voting is now closed, and 80% have voted for anatomical and functional evaluation.
Thank you. And I believe that is a very important message, and I'm happy to hear this. As clinicians, we're sometimes inclined to go for A or C because we have patients, we have symptoms, and of course we want to see if there's a diagnosis. When it comes to veteran athletes, it's very important to say that we also need the functional evaluation. We cannot just stop at the diagnosis or not. And for the reasons that we have discussed earlier, that many of these will have underlying disease. So this is not just a question of the diagnosis or not, because many of them will have. It's about also the functional evaluation on top of the anatomical evaluation. So I'm happy for the voting. And as we can see from the ESC recommendations in established long-standing chronic coronary syndrome, you should evaluate and before you give any advice, the type of level of sport competition, the profile of the cardiovascular risk factors, and that includes the fitness level of the individual. And then comes the functional evaluation, the presence of exercise-induced ischemia or arrhythmias, or evidence of myocardial dysfunction on echo. So both the functional and the anatomic history is important. As we can see here, if you do have no underlying ischemia and no underlying arrhythmias on functional testing, you are asymptomatic, and also you have an ejection fraction above 50%, you are eligible for sports, even if you have a low-risk lesion or after revascularization. So this is important to do both. So in summary, you can expect the presence of subclinical, mostly subclinical, I would say, coronary disease in a veteran athlete. So in all, that means that we should do risk evaluation in all veteran athletes to include risk profile, habitual exercise, and intended sports participation. In those with known coronary disease, the recommended evaluation before participation include both anatomical and functional evaluation. And this is, I think it's an important message. So just finally, one slide on if the recommended type of model from the ESC, which has been recommended already from 2011, that you should do a self-assessment of your risk, and if you have any risk factors or any symptoms, you go to your doctor for the scoring and then further testing when needed. This was recommended and used the years 2012 and 15 in the Two Ocean Race in South Africa, compared to the 4 preceding years without this model. And the incidence of all medical complications decreased 28% after the introduction of this model of self-assessment and risk assessment. So it may actually work, but you need a lot more patients and a lot more studies actually to prove this, of course, especially when it comes to sudden cardiac death. And with that, I would just like to say, I cannot be in London and you cannot be in Gothenburg, but this is how our city looks like, and you're welcome, hopefully, in the future to my city. Thank you very much.
Okay, thank you, Mats. Thank you also for putting our attention on the recent guidelines. And actually, you mentioned, this is very novel, that also patients with the coronary artery disease, established the coronary artery disease, and may now aspire to have an active participation in sport, including competitive sport, which is wonderful. We are opening the border of sport for a lot of patients that were before precluded. And so